Steve. Okay, hello and good evening, everyone. Welcome to our 34th Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Adam Gitacho. I'm the co-founder and CTO at Blue Edge Ethiopia. And it's a huge pleasure for us to have Dr. Henok Wale here with us, here to give us an update on the evaluation and management of adult sexual assault victims. To give you a little background on Dr. Henok is an assistant professor of obstetrics and gynecology, and he's currently working as a department head of obstetrics and gynecology at Harama University.
Good evening, everybody. Thank you, Adam, for the nice introduction. So today's webinar will be on the evaluation and the management of the adult sexual assault survivors. So Adam was saying victims, so I prefer to say survivors because it's more empowering. So regarding updates, it's better to say survivors rather than victims. So this will be the outline of my presentation today. So my presentation roughly contains around 80 slides. I'll try to be as fast as possible. To begin with an introduction, so there are different terms that are used interchangeably, but have different meanings. So these terms are usually sexual assault, gender-based violence, intimate partner violence. So let's begin with defining each of them. So sexual assault, it's like an umbrella term. It's an inclusive term, which refers to any form of forced or inappropriate sexual contact. These sexual contacts range from either forced touching, kissing, or to verbally or physically coerced vaginal, oral, or anal penetration without the explicit consent of the victim. So the word I want you to underline here is explicit. So there are more than 4 or 6 types of consents, and the term explicit is the better one used here. So sexual assault, it's an inclusive term. So the next is gender-based violence. So this constitutes usually physical, mental, social abuse, which include acts of attempted or threatened, usually done with some sort of force, manipulation, or coercion without the consent of the survivor. We have another term which is commonly used, intimate partner violence. So this is basically gender-based violence, but among current or former partners or spouses. So basically it has the same meaning, but the assailant and the survivor has a very close relationship, usually are partners or spouses. The last term is rape. So rape is non-consensual vaginal, anal, or oral penetration, usually by any sex organ, finger, object, usually involving force or the threat of force without the consent of the survivor. So there are different types of rape: stranger rape, acquaintance rape, and subset of acquaintance rape is known as date rape. So throughout this presentation, we will be using the term sexual assault because it's much more inclusive. So when we start with the epidemiology, the extent of the problem, almost 500,000, 500,000 cases of completed or attempted sexual assault is reported each year in the United States. This roughly translates into 1 out of every 6 American women has been the victim of either attempted or completed rape throughout her lifetime. And according to the study, usually for the past 25 years, almost there have been 18 million sexually assaulted women. So this is a very staggering number, among one of the highest in the industrialized nations. And it's no surprise that females are disproportionately affected. So every 9 out of 10 victims are usually females and usually younger age, usually reproductive age between 18 to 34 years. So this is a very staggering and large number. So this sexual assault is one of the violent crimes which is least reported in the United States. So only 10 to 15% of sexually assaulted individuals will go on to report to the police for different reasons. So it's one of the most underreported violent crimes in the United States. When we come to our country, according to the EDH 2016, among women between the ages of 15 to 49, 23% have experienced physical violence, and 10% has experienced some sort of sexual violence throughout their lifetime, and 4% of pregnant women have experienced intimate partner violence during her pregnancy. So this number is actually low than the actual incidence prevalence. This is because actually the true prevalence of this problem, sexual assault, will depend on the population being. So just to give you an overview of what I'm saying, so these are two separate studies that are done in different parts of the country, and the study population is different. So in the first population study was so Zion, his college studied around 385 female college students in Bahar Dar, and according to the study, the prevalence of sexual violence was roughly around 37%. And on the other part of the country, which mainly focused on housemates, the prevalence was found to be around 60%. So the true prevalence usually varies. The true prevalence depends on the population. So this problem affects all parts of the society. Even female physicians are not exempt from this problem. According to the Ethiopian Medical Women's Association, 50% of female physicians at some point in their life have been the victims or survivors of gender-based violence from their colleagues, bosses, or advisors. So it affects every aspect of the So this is the hospital where I work in. This is called Hiotfana Specialized University Hospital. So for the past 1 year, we have seen around 134 cases of sexually assaulted women who were seen in our hospital. So the impact of sexual assault goes beyond that single thing, that physical contact. It has a long-lasting physical, psychological, emotional, and possibly chronic medical implications. So these numbers reflect different long-term implications. So almost 50% of survivors will have difficulty reestablishing sexual as well as emotional relationships spouses or significant other, while 50% will contemplate suicide at some point in their life after the assault, and 20%, almost 1 in 5, will go on with that suicide. And roughly around 5% will sustain significant trauma that requires hospitalization and major operating. So this is a nice table that shows the long-term implications of sexual violence and sexual assault. So they will suffer from all this. So they will suffer from long-lasting depression, anxiety, eating disorder, sleep disorder. These are just a few of the long-term implications. So today's webinar will focus on how to evaluate and manage these sexual assault survivors. So we should start our evaluation with certain goals in mind. So there are several domains, and it includes the assessment and treatment of physical injury, with particular attention given to the genital assessment, and other components include psychological assessment and support, pregnancy assessment and prevention, evaluation, treatment, prevention of the sexually transmitted disease. And based on the setup, if it allows, forensic evaluation is part of the one component of the evaluation. So when we begin, we have to set the right environment. So the assault victim or the assault survivor should be comfortable in the setup. So the first thing is to set up so these are some of the basic equipments that are needed to properly evaluate. So every hospital that evaluates sexual assault survivors should be equipped with this, with the exception of maybe colposcopy. So colposcopy, if it's available, it's very good. In our setup, we are fortunate to have it, and it helps in evaluating subtle genital lesions. So these are basic equipments that should be fulfilled. So before starting your examination, start by introducing yourself, and ensure that one person accompanies, usually chaperone accompanies the survivor, whomever they choose. And you should thoroughly take time and explain what's going to happen during each step of your examination. So why you are doing each step of your examination, what will it tell you, how will it influence the kid that you are going to give them. So it should be, you should take time to explain it in detail. So there is no rush in evaluating the sexual assault survivor. So one session might take 3 to 6 hours to fully take history, physical examination, forensic evaluation. So you should explain every component thoroughly, and you should ask consent for each component of your evaluation. So reassure that one of the most important things is to reassure the victim that they are in control. They are in control of the pace of the examination, the timing, the component of the examination. So they might give consent for one component and they might decline for another component. So it's entirely up to them to dictate the pace, timing, and component of the examination. So this is very important for you to understand. So take as much as time as possible, give them time. You should reassure them that the examination is going to be entirely confidential unless they are planning to litigate. So unless they are planning to bring charges, so every component should be kept confidential. So review the consent form. Like I said, they might give consent for one component of the evaluation and may decline for another. So before starting your examination, you should review the consent form. So examination should be done as soon as early as possible, and do not force them or pressure them to do anything against their will. So little details matter. So what I mean by this is, so we follow what's known as trauma-informed care approach. So this includes open and accepting body gestures, using empowering words, and like that. So when we say like opening and accepting body gestures, it's very important. Like keep your arms uncrossed. You should keep your hands in view at all time, and at all time you should be facing the patient, making direct eye contact. So at no point in the examination should you be typing or appear distracted. So you should give your full undivided attention for the assaulted. So when I say little things like it says here, for example, do not block the door. So always you should sit opposite to the door. So it's understandable. They have been sexually assaulted. They have been a victim of either physical sexual assault. So if you appear to block the door, that will create a sense of being trapped. So that will exacerbate their anxiety. So little details matter. So do not block the door, make eye contact, use open-ended questions, and you should always appear empathetic, non-judgmental. So these are skills you acquire through time. So you should use what's known as trauma-informed care approach when evaluating. So during your conversation, it's very important that you try to normalize the experience. I know it's not a normal experience, but try to normalize it as much as possible to make them comfortable. Like use words like, many people have experienced this trauma, many people have gone through this. It's totally normal to feel this way. And also use empowering language as much as possible. Like, you are strong, you survived this. This is okay. I know it can be hard. Thank you for your courage, for sharing this with me. So these things matter. They have their own implications. So try to normalize the experience as much as possible. Use empowering language. At no time should you appear shocked, afraid, or disgusted by anything they tell you or by anything you are finding during the examination. So after setting the proper environment, the next part is taking history. So this is very important. Taking history will guide your trauma assessment. So your physical examination finding trauma assessment will depend on the history that you take. Taking history will also guide you for risk assessment, pregnancy risk for acquiring STIs like gonorrhea, chlamydia, RV. So you should take thorough history. So it has its own implication for also litigation. So you should take thorough history as much as possible. So different setups have their own different prepared format for history physical examination. I encourage all that work in this gender-based violence assessment to prepare their own evaluation tool. So full identification should be documented, like name, address. So the basic stuff. So identification should be documented in detail the date and time of arrival of the survivor, the date of examination, was there any interpreter? So you should understand you might be called up to court at any time. So proper documentation not only helps the survivor, but will also help you. Properly documenting is the responsibility of the physician. So the next part is taking a detailed survivor's history. Like I said, this will direct your trauma assessment, will direct the risk of different chronic medical or acute medical conditions. So like date of the assault, time in which it occurred, the location, the place, information regarding the assailants. Was it one? Was it two? Were there multiple? Was it a stranger? Was it known for the survivor? It should be documented. So is there any documented case of loss of consciousness, any amnesia, any trauma, bleeding that occurred at the time of the assault? So was force used? Was any weapons, verbal coercions? It should be clearly documented. So was there any drugs involved, either the assailant or the assaulted? Was there any drug use involved? It should be clearly documented. So another important thing is, was there any penetration of any orifice? So this will guide your forensic evaluation as well as risk assessment for STI. So was there a penetration of the anus, the vagina, oral cavity? So what was used? Was it a finger, an object, or a sexual organ? It should be clearly documented. Another is did ejaculation over? So many may not recollect, but it's either way it's important to ask. So if yes, the location of ejaculation should be documented. So was any contraceptive used? Should also be part of your assessment. So another pertinent is really last normal menstrual period to assess for possible risk of unwanted pregnancy. Was there any recent anogenital injuries, surgeries, diagnostic procedures done that might affect your interpretation of the physical examination finding? Was there any history of recent consensual intercourse within the past 5 days? So this will guide, basically this will affect your forensic specimen collection if they had consensual intercourse in the previous 3 to 5 days. Anyway, it should be asked, was there any barrier contraceptive? So post-assault hygiene should also be documented, as this obviously will lower the yield of the forensic specimen evaluation. So did she take off her clothes, change her clothes? Did she shower, defecate, vomit, drink, smoked, wiped? All these things should be documented. So after taking your history, physical examination will be the next part to thoroughly take physical examination. So your history will guide your physical trauma assessment. Our history will guide our physical examination. So one simple mnemonic that you can use during your evaluation is to use the term tears. So what you are looking for is basically any tears, fissures, lacerations, any chemosis, abrasions, or redness. So that this abbreviation will guide for what you are looking for. So basically, you begin with general physical examination, which is vital signs, general physical appearance. So was she tearful, shaking? Does she appear worried? Was she conscious on arrival? Was there any depressed level of consciousness? It should be clearly documented. So ideally, physical examination findings, if available, should be taken in the form of photograph. If the hospital has digital camera or colposcopic documentation is very important. Unless otherwise, you can simply document using a simple drawing. So if your setup is equipped, such as for possible forensic evaluation, if the person hasn't changed any clothes, so ask them to undress if they feel comfortable, and you should lay a sheet underneath to capture any falling debris for possible medical evidence. And you should then fully clothed, gown and warm blanket should be given. So first thing is first, any life-threatening injury should be addressed. It could be genital or extragenital. Life-threatening conditions should be first addressed before we go any further. So, like I said, if possible and if available, the camera or if the patient consents, injury should be documented in the form of photographs. And a ruler or easily identified object usually will be helpful, indicating the size of the objects or the size of the lacerations or injuries. So the most common form of injuries in the sexually assaulted women is extragenital trauma. So genital traumas are not that common. So the most common forms of trauma are usually extragenital, and with particular attention should give to the face, to the neck, to the breast, inner thigh, and the upper arm. So these extragenital sites are usually the common sites for injury. So this is the proper way of, or the preferred way of documenting any trauma that occurs. So basically, if you have digital camera, it should be documented this way. So if you can see in the upper right corner, so you should use ruler. So there is a very areolar bite mark there. So they are using a ruler to describe the relative size. So this is the ideal way of documenting any physical examination findings. So for obvious reasons, most of our hospitals are not equipped with this digital camera. So that doesn't mean, so we can simply use this drawing method to document any trauma. So as you can see, detailed description is made. So the location will be pinpointed. The type of the lesion, is it bruising, abrasion, chemosis, and the relative size. So the dimensions of the lesions could be clearly communicated. So this is very easy way of documenting any trauma. So I encourage everybody to prepare such type of drawings for your next evaluation. They are relatively easy to prepare. So after extragenital trauma, so particular attention should be given for genital trauma evaluation. So all these things should be evaluated thoroughly in a systematic fashion. So once you have been accustomed or once you have been experienced, it tends to become relatively easy to systematically evaluate all these parts. So common sites for genital injury are usually the posterior foresheet and that of the labia minora, but as compared to females who have had consensual intercourse, females who have been assaulted are more likely to have genital injury at the sites other than the posterior foresheet and are more likely to have multiple injuries. So this picture demonstrates usually the common sites for genital trauma. Usually we find the chemosis, abrasion in these sites, usually posterior foresheet and inferior margin of the labia minora are the most common sites. But in case of assault, usually they tend to be multiple different sites. So before you do genital evaluation, every clinician or physician should be familiar with the normal variants of the hymen and the external genitalia. So I have witnessed multiple cases where they were mistakenly documenting normal cases as hymenal tears or abrasion because of the inability to recognize the different types. So the most commonly mistaken types are the posterior and the anterior lunar type are usually mistaken for possible hymenal lacerations. But you should always keep in mind the normal variants of the hymen when you are evaluating genital evaluation. So what are we looking for in the hymen? So when you are evaluating, so the first thing is abrasion. So abrasion, we call it in Amharic mafafak, magdagat. So hymenal abrasion is one of the common things to be discovered following sexual assault. So again, it's much more common in the posterior foresheet and the labia minora. So these findings are usually time dependent. So in prepubertal, they tend to heal relatively quickly. Within 24 hours, these abrasions will heal, as opposed to in the adult and adolescents usually may last as long as 4 days. So for those coming usually after a week, these findings may not be found. So the timing also matters. So abrasion is one of the things we are looking for. So if you find the abrasion, the site should be documented. The site, usually we describe it in terms of clock. So like 6 o'clock, 7 o'clock, and the size should also be documented. Usually they tend to be multiple sites. The other common finding is blood blisters. So these are thin vesicle bloods on the surface of the hymen that have resulted from usually rupture of the small blood vessels within the hymen, and usually accompany hymenal laceration or hymenal tear. So these findings are actually relatively may take longer time to disappear. So they might last as long as a month for healing. So again, they tend to be common in the posterior aspect of hymen, and usually they tend to be multiple. So their presence should be clearly documented, as this is usually an evidence for penetrative intercourse. The other is submucosal hemorrhage or ecchymosis. It's also a very common finding. Again, this is also common in the posterior quadrant of the hymen. So this resulted from bleeding into the areolar tissue beneath the mucosal membrane, and usually takes around a week to heal. So usually in the early days, within the first 24 to 48 hours, this will appear bluish, and subsequently this bluish discoloration will be lost. And after 4 or 5 days, this finding might be lost. So early presentation is very important. So the most common and one of the most obvious findings you might find is hymenal laceration. Hymenal lacerations are usually common in the those evaluated in the pre-pubertal, adolescent, and sexually inactive adults. Usually these findings are common. Again, the most common site for hymenal laceration is the posterior fourchette. Posterior laceration is common, accounting for almost 88% in the pre-pubertal and 61% post-pubertal females. Again, they tend to be multiple sites, so their exact sites should be documented. So lacerations are usually an indicative of penetrative intercourse. So, I'm not saying this is the only things that might result in this genital findings. So tampon use sometimes might actually result in such findings, but these findings should be clearly documented, their size, and sites should be clearly documented by the physician. So whenever you are evaluating, what I want you to emphasize is that whenever you are seeing these genital injury patterns, I don't expect you to say this is due to sexual assault or consensual assault, consensual sex or sexual assault, but because both might be present, so in consensual as well as in that of the sexual assault. So your job is to say that there was penetration or not, was there genital trauma or not. So you're not supposed to say this is an assault, this is a consensual sex. Your only job is to document this pattern of genital injury is there. So this is very important. Saying this, usually tears, ecchymosis, abrasions, redness in sites other than posterior fourchette are usually the result of sexual assault rather than consensual sex. So the most common pattern of genital trauma that occurs after consensual sex is usually ecchymosis and tear in the posterior fourchette. So these sites other than posterior fourchette, usually if you find tears, ecchymosis, abrasions are usually the result of sexual assault. But you're not supposed to say this is due to sexual assault or consensual assault, because you cannot say that with 100% confidence. So your job is to report the pattern of genital trauma. So there was tear, ecchymosis. The rest we leave to the prosecutors to do their job. The other is colposcopic examination. Most centers are not equipped with this examination tool. In our setup, we are fortunate to have it, but it's underutilized. We almost never use it. This is important in identifying subtle genital trauma. So those who might be difficult to see with the naked eye, you can use colposcopy with a dye called toluidine dye, which is blue dye. This will help identify sites of subtle trauma. If you have UV light source, this might direct your specimen collection, especially is very important in identifying semen on the skin or the closing or any or closing of the survivor. So this is an example of colposcopic examination. So you can see clearly after applying the toluidine dye. So toluidine blue dye usually adheres to the injured nuclei of damaged epithelial cells. So usually it will make it more obvious. So after the dye, you can see areas of genital trauma abrasion, which is seen more clearly. So if you have a colposcopy in your setup, I encourage you to use it during your evaluation. So you can document it, you can take photographs, which is a much more good evidence. So this is the utilization of UV light. So if you have UV light source, it will help you identify semen on clothing or on the survivor usually, but it might also be associated with false positive due to use of certain detergents, creams. It might be false positive, but the main purpose is to direct your forensic specimen evaluation. So there are two special populations we should consider during our evaluation. The first is the elderly. So this sexual assault also occurs in the elderly. Usually it's common in the elderly group homes and usually accounts for 1% of all sexual assault cases. So they are more likely to sustain serious injury because of decreased estrogen level. So they are more likely to suffer serious genital trauma as well as bodily trauma. So fractures are more common in this population. The other is taking history might be difficult because of usually failure of recollection, usually because of memory impairment. There might be problem with reporting, and usually in case with severe memory impairment, there might be an issue of obtaining consent for certain examination. The other special population is usually with usually victims of physical and cognitive disabilities. So again, this population is relatively at risk for sexual assault because usually they cannot give consent for any sexual activity, and because of cognitive disability, there may be issues of regarding giving consent during your evaluation, and taking history might also be problematic. So for example, if you have hearing impaired survivor, you should use interpreter, language interpreter, sign language interpreter to communicate this issue. So these two populations require or deserve extra attention during your evaluation. So depending on the availability of forensic laboratory, you should document any specimen that you have sent. You might take any swabs. So commonly done in our setups is usually taking buccal swab, vaginal, anal swabs are common. So anything else you have sent, clothing for possible forensic evaluation, body cavity, the samples should be thoroughly documented on your in your charts. So all these things, if you have sent, you should clearly document that you have sent. So in a setups that are capable of providing DNA, so additional samples such as fingernail clippings, fingernail scrapings, pubic and that of scalp hair samples should also be sent. Again, if the survivor gives you consent. So if you send, these things should be clearly documented. Any foreign bodies that are found, either intravaginal or rectal, should be clearly documented on your chart. So that's the evaluation. I hope I'm not going very fast. So we'll go to the management. So after evaluating your detailed history, physical examination, then comes the management part. So the management should be multidisciplinary. So as a primary physician, your job is usually to provide the medical assessment and medical management, but they require much more than that. So they require psychological counseling, care, possible legal support, social support. So that's our job. In addition to providing our medical management, we should link to the appropriate counseling and caring centers after we are done. So when we come to the medical management, so this basically focuses on addressing any injury, such as fracture, soft injury, tissue injuries, possible strangulation should be addressed first. So any life-threatening conditions, serious condition should be addressed first before we go on to the next medical management. So after addressing these serious issues, our next step is going to be addressing providing prophylaxis for STI, providing prophylaxis against tetanus, preventing pregnancy, and managing the psychosocial issues that are associated with this trauma. So treatment will depend on how soon they come after the incident. So I want you to divide treatment into those who have come within the first 72 hours and those who have come beyond 72 hours. So for those who have come within the first 72 hours, like I said, first life-threatening conditions, acute conditions should be treated. After that, so any wounds, tears, lacerations that needs possible cleaning should be cleaned, should be sutured before going into the next management. So address acute issues first. So the next is to provide prophylaxis against an STI. So data is very limited regarding the risk of acquiring STI after sexual assault. This is because most sexual assault survivors will not come for follow-up. So we don't know if they have developed STI or not. So it's very difficult to assess the risk of STI after sexual assault. But one French study showed that the risk of acquiring chlamydia was around 15% and gonorrhea around 5% after sexual assault. So because they don't come for possible follow-up, it's your job to provide this STI prophylaxis. So the preferred regimens are usually those that cover gonorrhea, chlamydia, and that of Trichomonas vaginalis, T vaginalis. So ceftriaxone to 500 milligram IMSTAT. So previously it was 250. The current CDC recommendation is to give 500 milligram IMSTAT to cover gonorrhea, plus give doxycycline 100 milligram BID for 7 days, or alternatively azithromycin 1 gram piostat to cover chlamydia, and metronidazole. You have also an option of 7-day or 1-day regimen. So regarding doxycycline and metronidazole, the preferred regimens are the 7-day regimens rather than the stat doses, because, for example, doxycycline has been shown to have a better microbial coverage within the 7-day regimen compared to that of the azithromycin. But the problem, like I said, most patients, they will not adhere to the drugs. So you should do possible, are they going to adhere for the 7-day regimen? So after assessing that, you should decide whether to give the doxycycline and azithromycin. The same is true for metronidazole. The 7-day regimen is much better than the single dose tinidazole or metronidazole. So again, patients might decline. So they might refuse prophylaxis antibiotics. For those who decline, it's better to appoint after 1 week for possible reassessment based on the initial testing. The other is PEP against HIV prophylaxis. Again, the data is limited regarding the risk of acquiring HIV after sexual assault. So these are actually some data that shows the risk of acquiring HIV after different types of intercourse with an HIV positive person. So insertive penile vaginal intercourse, roughly the risk of acquiring HIV is 1 in 1,250. So this is very low, roughly around 0.08% following vaginal, around 2% following anal intercourse. So despite the relative low risk of acquiring HIV, and despite data lacking to show that the effectiveness of PEP in preventing HIV infection after sexual assault, most institutions and experts recommend giving PEP for those who have come within the first 72 hours. So preferably, it's better if it started within the first 4 hours, but it can be offered until the next 72 hours. Usually, if they come after 72 hours, there is no benefit of giving this post-exposure prophylaxis. So this is our national guideline for PEP. So sexual assault victims are considered to be high risk. So 3 combined medications are preferred, and usually this should be taken for the whole of 28 days. So the problem again with PEP for RVI is to adherence, the issue of adherence. So meta-analysis of 26 studies have shown that only 40% of individuals were adherent to the 28-day regimen. So adherence is a very serious issue when it comes to post-exposure prophylaxis with RVI. Again, for PEP for hepatitis B should also be offered and given. So our guideline actually recommends giving hepatitis B vaccine without the immunoglobulin in cases of sexual assault, but other setups, they have their own different recommendation depending on the serostatus, immunostatus, documented immunostatus of the survivor and the hepatitis B status of the assailant if it is known. So in our setup, our guideline recommends giving only hepatitis B vaccine. So tetanus vaccine, this is the protocol for giving TT vaccine. So basically all that come after usually 6 hours and previously received less than 3 vaccinations. It's very important that you consider giving TT vaccine. So this is also a recommendation by the CDC, and also American College of Obstetrics and Gynecology also recommends this, that HPV vaccine should also be given for sexual assault survivors. So both for male as well as female after the incident. So females with the age range of 9 to 26 and for males with 9 to 21, you should consider initiating the HPV vaccine. This is not currently in our guideline, but this is very important. If the vaccine is available, this should also be offered. The other issue is the issue of preventing pregnancy. And so this actually could be expanded into the next 120 hours or the next 5 days. So there are different options. So if you are interested, there are algorithms on which ones to choose, which emergency contraceptives to choose, which emergency contraceptive. So there are 2 intrauterine devices. So there is somebody on the comment saying the preferred regimen for PEP is TDF, 3TC, and DTG. So DTG is actually contraindicated in sexual assault survivors. It's not recommended to give that. So going back to the seminar, so these are all possible options. So copper and levonorgestrel IUDs and that of ulipristal acetate, selective estrogen receptor modulator, will be given up to 120 incidents. So emergency contraception should be offered. So for those who have come after 7 hours, it's very important to treat for STI on subsequent follow-up if there is any symptom of STI. The patient has symptoms and if there is any lab evidence of infection. So PIC should be done, but PEP, like I said, is not PEP is not recommended for those who come after 72 hours. For regarding those who come usually after 5 days, we do not provide emergency contraceptive, but on subsequent follow-ups, usually we'll do subsequent pregnancy tests, but the options should be clearly communicated to the sexual assault survivors. So these options are usually, they might choose to keep the pregnancy. In that case, you tell her about ANC. If she wants to, if she doesn't to do abortion, or if she doesn't want to keep the baby, you will tell her regarding adoption services, foster centers, and of course, one of the indications for abortion in our protocol is for sexual assault survivors. So the options, if she becomes pregnant, should be clearly communicated before they go. So after the medical management, it's our also responsibility to link to other centers. One is psychological issues. So they suffer from chronic debilitating psychological issues such as anxiety, fear, physical pain, sleep disturbance, anorexia, suicidal ideation are very common among this population. So after you are done your evaluation and medical management, you should link with the proper center for psychology. Requires an ongoing assessment. It's not a evaluation. Social issues are also very important. So after done with the evaluation, you should ask the survivor if she has any safe place to go. So this is especially true if it is date rape or intimate partner violence. So it's very important that you not send her to the same situation that led to this assault. So you should ask if she has any safe place to go, if she has anybody she trusts or that could accompany her, and you should provide possibly a resource list of organizations. So there are women, children organizations that might be able to support their social needs, legal and assistance with the this is also a very important component. So according to our guideline, follow-up is very important. Like I told you, most will not come because of embarrassment for possible follow-up, but it's very important that you advise them that these follow-ups are very important and have implication for long-lasting chronic medical psychological issues. So it's very important they come back. So according to our guidelines, so 3 visits are needed after the initial evaluation. So the first is at 2 weeks, then 6 weeks, and hello, is it audible now? I'm sorry.
Yes, it's audible. You're audible now.
Okay. So our national management guideline recommends 3 visits after the initial visit. So the first visit will be on the 2 weeks after the first visit, and the purpose. So each visit have their own purpose. The first visit is to screen for pregnancy and manage accordingly. So you should do HCG. So emergency contraception is not 100% effective. So you should screen, you should test for HCG. And so you should conduct a brief clinical evaluation to assess any change in the previous findings. So you should check their adherence to antibiotics. You should check their adherence for PEP for RVI prophylaxis. It should be checked, and you should reassess their emotional, mental status, and basically refer as needed to the proper centers. The next visit will be at 6 weeks. Again, we are going to, by this time, we expect all medications to be over, and usually ask about their compliance, whether they have finished the PEP, the full course. You should screen for STI. Pregnancy test again should be repeated. And at all visits, it's very important that you assess their emotional status, so and response for possible need for psychological care. The last visit is usually at 3 months, and again we'll screen for STI, assess their emotional status. This is unique in that you test for syphilis. So we don't provide prophylaxis for syphilis, but we'll test the presence of syphilis usually at the 3rd visit, and serum test for HIV should be repeated at 3 and 6 months. So again, assess their emotional and mental status and treat and refer as appropriate. So who can give the evaluation? So the sexual assault survivors who can evaluate, take physical history, physical examination. So in other setup, there are trained individuals, particularly for this purpose, called sexual assault nurse examiners and forensic examiners are available. In our setup, our guideline recommends that general medical practitioners as well as specialists should provide care without the need for specific training. So again, this is not only one individual can provide all the services. So this is again a multidisciplinary approach, Solana. So it requires multiple physicians. In the other case, mid-level other healthcare providers where general practitioners are not available, they might do this evaluation provided that they have undergone special and specific training on the how to evaluate and collect specimen. So this recommendation for ACOG is very important and applies to all of us. So a physician who has no experience or limited experience should consider requesting an assistant to ensure proper evidence is collected. So don't be ashamed always to ask for help. This is very important, and it's a very important recommendation for ACOG. So if you have any doubt, if you are not confident enough, so always ask for assistance, as these are sensitive cases. So as a physician, what are our roles? So our roles are working in conjunction with trained nurses for the sexual assault survivors, providing support and resources, maintain professionalism and good working relationship. And as physicians, we should do more researches. So more researches are required so to reach at the root causes for these problems. So I encourage everybody to do research in this topic. There are many untouched areas regarding this topic. So what are our legal obligations? So as an examiner, what are our responsibilities? Your responsibility is to document the records properly and accurately. So you should be honest. You should document what you see. You should take detailed thorough history and physical examination. Take appropriate pictures. If no pictures, make sure that there is proper pictorial representation of your findings. So you should always be honest. So again, document injuries preferably with diagrams. Additional information collection methods such as photography, videography, other documentation should be taken with consent. So every part of your evaluation should require consent on the part of the sexual survivor. So they might give consent for one part and they might opt out for another. That's entirely up to them. You should review the consent. Always review consent before doing any examination. So collect samples to be sent for forensic evaluation whenever possible. And your job is to provide medical legal certificate. So one thing I see usually on medical certificate is they say sexual assault, sexual assault. That's not your job to reach at the conclusion. Your job is to document your findings. So the rest we will leave up to the police, to the court. So don't say with 100% certainty this is sexual assault. So your findings to find to document what you see. Okay, this is a very important point. So thank you very much. I hope my voice was audible.
Yes, it was quite audible for the most part, and it was a great presentation, Doctor. Thank you so much.